Welcome back to This Week in Immigration. I'm Jordan Lapierre. On the program this week, a detailed conversation on how health issues fit into the immigration system. Stick around. We have something a little different for you this week. Our Theresa Cardinal Brown sat down with Ruth Wasem, a BPC fellow and professor of practice at the University of Texas LBJ School, to discuss how the U.S. immigration system handles the health issues of migrants. As the coronavirus continues to impact every aspect of daily life and the Trump administration uses public health concerns to limit immigration, Theresa and Ruth dig into the history behind these actions. Here's their conversation.
Hi, everybody, and welcome back to This Week in Immigration. I'm Theresa Cardinal Brown. I am very pleased to welcome to our podcast this week Ruth Wasem. Ruth is a professor of public policy practice at the LBJ School of Public Affairs at the University of Texas. And prior to that, she spent 25 years researching and writing about immigration law and policy as a specialist at the Library of Congress's Congressional Research Service. Her job there was to educate lawmakers and their staffs about all aspects of immigration law and policy to help them as they were formulating legislation and overseeing government agencies. So she has a vast knowledge and expertise in our immigration law and systems, and I am happy to welcome here today. She has also joined us as of last year as a BPC Fellow for our Immigration Project. Ruth, I wanted to talk to you today because you have such a great deal of background experience about something that is very right now in the news, which is how our immigration system deals with health issues of migrants and immigrants. So in the Immigration and Nationality Act, as we know, there is a section that says that people can be excluded from coming to the United States if they have certain public health diseases. And that's been used in the past and off and on in different ways. But we've now seen it being used by this government and to try to address the pandemic. So we're going to go way back in time to start. Where did the United States first start looking at health issues for immigrants coming to the United States?
Well, Theresa, thank you. And I'm honored to be on your podcast. And this may be one of my first official acts as a fellow at the Bipartisan Policy Center. So this is a treat. If you think about it, we've been concerned about the health of arriving immigrants since colonial times, because it was not uncommon for people who took that long journey across the ocean to get sick at sea. And so there a concern with identifying people that were sick began from the onset of our nation. It was generally done in colonial times, and in the early federal period, it was up to the states to handle this. And the practice was to quarantine. If people were sick, when they arrived by ship, they were quarantined. There were medical facilities set up that were primarily for immigrants, or arriving immigrants. Sometimes they were not allowed off the boat, and unfortunately, some, of course, would not survive then because they didn't get medical care. But generally speaking, we have been concerned about the health of arriving foreign nationals since the beginning. However, it wasn't anything that was put into our laws until 1891. And there had been some earlier, you mentioned, the grounds of inadmissibility at the beginning, that one of them is public health. So we started when the federal government started exerting its plenary authority over immigration, the earliest exclusion laws focused on criminals. And there was a concern, and had long been a concern, about people that might be public charges. That also dates back to some of the colonies who had poor laws and bars on public charge. So often the public charge ground was used if someone was sick because they looked like they couldn't work and provide for themselves. But in terms of communicable diseases or contagious diseases, it really took the outbreak of of TB in the latter half, tuberculosis in the latter half of the 19th century, as well as cholera and some of those diseases, to raise a concern to actually put it in the statute. So it was in 1891 with a series of a whole set of immigrant grounds for inadmissibility that were added to the law. Now, you know this, but some of our listeners wouldn't know that our earliest immigration laws didn't talk about the qualities of people coming in or what it, how you, the affirmative side of becoming an immigrant. They only looked at things that would disqualify you.
Right. So the immigration laws were say, you can come in unless you have one of these issues.
Exactly.
And now our laws say, you have to meet these particular criteria in order to come in. Oh, and also you can't have any of these.
Exactly. So the earliest laws focused on exclusion, and public health was one of those. It was couched as part of physical limitations and mental deficiencies as well. But the line about contagious diseases and what later evolved into public health concerns was originated in 1891.
Yeah. So, and you mentioned a couple of the diseases back then that we're most concerned about, tuberculosis, cholera. What are some of the other diseases? Smallpox, was that an issue? Or
it probably was, at that time, the concern, knowledge, they were just beginning to learn about germs in the late 19th, early 20th century. So science was new. And the focus again on immigrants bringing diseases, it wasn't scientifically based in the early days. It was much more linked to people's attitudes or nativist views about immigration. So there were stereotypes that Irish had, were more likely to have cholera, or the Jewish people were more likely to have TB. They talked about the Chinese bringing the bubonic plague, things like that, but it wasn't scientifically based. And even, what struck me as surprising was even during World War I, when we had the great influenza.
The Spanish flu, they called it.
Yeah. We didn't restrict immigration on the basis. Now, we still checked people. And in the early days, this was before, so these exclusion laws were put in before we had visa consular officials abroad issuing visas, because visas didn't enter the scene until World War I. So in the early days, it was all done at ports of entry. And
so after you arrived, they would check you for all these things.
And so the medical checks happened. And so it was all at all the major ports of entry, like Ellis Island in New York, Angel Island in San Francisco, Galveston. All the major ports of entry had medical screenings of immigrants. And it was an important role that they played.
So let's talk about a distinction real quick here, because all of the places you mentioned were seaports. So we're talking primarily of screening of people coming by boat to the United States from Europe or Asia or maybe South America. But our land borders were fairly open at this time. Did we have the similar kinds of checks there?
Not that I'm aware of. My guess is that if we were concerned about something coming in, but the Border Patrol didn't come until the 1920s, whether we were checking people coming from Canada and Mexico in the same way is a very good question, and I'm not sure what the answer is. It could have been, but I don't remember reading anything about it.
Yeah, we'll have to. We'll look into that for another podcast.
I think it might have, where it would have happened would have most likely been local officials in those communities. I don't think the federal presence along our land ports of entry was as great until later in the 20th century.
Yeah. So let's bring the laws up to date. You said they first came in 1891. We had the Major Immigration Nationality Act in 1952 and then amended again in 1965. And that's the basis, basically the law we're working under today. Did those laws fundamentally change any of those health-related grounds of inadmissibility, and what happened after that?
Well, the 52 Act, codified a lot and pulled together by then about 36 grounds for inadmissibility. And the public health concerns of contagious diseases remain nested in that broader mental and physical deficiencies. That stayed through the 65 Act and was not changed until the 1990 Immigration Act totally revamped the grounds for inadmissibility, and instead of having over 30, brought them down to 9. And by that time, then what we now think of the public health ground, it was the 1990 Act that formed the basis of the law that we work with today. And that's where the importance of communicable diseases, as well as and of course by now we have visa officers abroad, and the requirements before you get a visa to have a medical exam. So there's a lot and it was in the 90 Act that it assigned the Secretary of Health and Human Service the responsibility for identifying the diseases. So the Immigration Service wouldn't be the agency that would say what it was. The Secretary of Health and Human Service, by regulation, would list the communicable diseases, and also making sure that diseases where we have vaccines, to require that people are vaccinated before they come to the United States.
So that's the laws that we're operating under right now. And so, as you mentioned, the Secretary of Health and Human Services, or one of his designees, has this list of communicable diseases of public health significance that now DHS or CBP operate under when they are checking people at the border. So can you talk to us about that list, and how frequently is it updated, and when do they look at it, and what's on it?
Well, some of the diseases, the 7 diseases that are, it's kind of, gonorrhea, certain active infectious leprosy, active TB, there's about 7, syphilis, and there are other diseases incorporated in executive orders as well. And so cholera, diphtheria, smallpox, yellow fever. There are classes of diseases like the viral hemorrhage fevers, and that's where Ebola, for example, falls under that. There's severe acute respiratory syndrome,
SARS. Yeah. So more recent things have been added.
And more recent things that get added. There's some, nothing that we would want to have. Some of them are more obscure, and I don't even know how to actually pronounce them. And that's why I skipped over them.
Well, one that I'm pretty sure is on there is pandemic influenza. And so that's what we're facing right now. But as you mentioned, now that we have this whole scheme of visas issued overseas for most people who are coming to the United States before they arrive, how does the government check for this, right? So they have this list of diseases. If you have to get a visa overseas, who gets checked for this before they leave? Who gets checked when they arrive? And how does that work?
Well, this is where it gets interesting, because generally speaking, when you're going through the process of applying for a visa, you're required to have a medical exam. And there are the consular office has a list of physicians who they recognize as being able to provide that. So people have a medical exam.
Now, is that everybody? Is that green cards or non-immigrants?
That's pretty much everybody's required to have a medical exam. There are waivers for certain categories, but here's the rub. As you know, your visa can be good for up to 10 years. So you can have a medical exam, you can qualify for a visa, and then get sick or get exposed to something. So the system is set up that then you should also be whether or not, so the law is clear that we can examine people at the port of entry as well. Mm-hmm. And if someone appears to be sick, and likewise airlines, because now we're not, very rarely are we getting on the boat, we're getting on the plane. And airlines are very aware of not letting people on that appear to be contagiously sick. And so, but that they don't have the same authority as immigration law. So it's having people get, and again, some of these diseases you get vaccinated for. Others, if it turns out you have TB, and this has come up with people coming from refugee camps in particular in the past, then instead of banning you from coming, you have to show evidence that you're going to get the treatment, and then you come back and show that you've taken the medicine for TB. So there is some flexibility, there are some waivers, but it should be a two-step system that where you have the medical exam, but it's at inspection at the port of entries or boarding the plane that we certainly don't have health professionals at that location.
At every place, yeah. So my recollection when I was working at an embassy abroad, for example, is that if you're coming on a visitor visa or a temporary visa, you wouldn't necessarily have to have a medical exam, but they would ask you all the questions, right? They had a very long questionnaire. Have you ever had any of these things? And if you answered yes, then you would be sent for a medical exam. Or if during the consular interview, the consular officer was concerned, you might be sent for a medical. But everybody getting an immigrant visa who's going to be permanently coming to the United States, they have to have a full medical exam by a panel doctor. It has to be included in their application and everything else. So it's a little kind of maybe up to the consular officer overseas.
Exactly. That's where the waivers come in. So in general, they weren't requiring it of non-immigrants in the same. The law has it in that it's a ground for inadmissibility. It's who gets waivers, and what's the common practice. And non-immigrants generally are not. For a whole host of these visas, are not screened as rigorously as someone coming over to be a legal permanent resident, which is troublesome when you think about highly contagious diseases, and someone, even if they're just coming for a brief visit or a business meeting or conference, that we though you could, as a consular official, you could require it of someone.
Yeah, but there are millions and millions of these visas
Exactly.
a year, right? So
Millions. And and it just seemed burdensome.
The other thing that's interesting is that we started out talking about how it was basically the states when people arrive that would kind of look at them and say, "Oh, you kind of look sick," and even if there is this check abroad before you get a visa, as you mentioned, it still kind of comes down to that CBP officer at the port of entry to go, "Huh, you kind of look sick," and they're not doctors, they're not medically trained. I think one of the things that a lot of people are concerned about, and I'm sure you ran into this when we were talking to lawmakers, is, especially when we're in the pandemic right now, how robust is our system for really being able to test and know? And what kinds of things have lawmakers looked at to try to beef up the system?
Well, one of the things that I remember back when we were working on both swine flu and Ebola, I was still on the Hill then, and the concern was whether the Public Health Service Corps, whether they were adequately staffed and available to CBP to be at key locations.
Right. So CBP could say you can only enter at these 10 airports where we know we have public health officials who can do this screening, right?
Particularly if you're coming, and what you would do is, you wouldn't go, you wouldn't eat your peas with a knife. You would be strategic. You would look at people coming from flights or places. You would want to direct it more that if you're and this is what they did with Ebola. If you're coming in from certain places, then you're good. That's where those are where we would have the public health officials, and so you try to target and channel and have a risk assessment model of going forward. And so it's having that kind of planning in place. A strategy, and knowing, well, what would you need? Because these pandemics happen. This is not new. This might be particularly bad right now, what we're dealing with, but with COVID-19. But coming up with a strategy in terms of having the resources of health professionals in the Public Health Service Corps, which, by the way, is one of the oldest government entities. It dates back to the early federal period, the Uniform Public Health Service Corps, and this was one of the things that they did was monitor people coming in with and disease control and provide medical attention. So, as well as they also took care of our Navy, our own soldiers. So they were played that role. But so yes, I think it's very important that there be better planning and so we can deploy these resources as needed in ways to be responsive.
So there's been a lot of debate, and I'm curious your perspective on this about whether efforts to stop travel to the United States, close the borders, restrict entry of immigrants, all of these things actually work to prevent either the introduction of or spread of a disease in the U.S. Public health officials have looked at this, but you've done research, I assume, on this from CRS. And what does sort of the evidence that you've looked at say about that?
Well, I haven't looked at the current COVID. My stuff is based on Ebola and swine flu and the bird flu epidemics of the early 20th century, or the early 21st century. And then it appeared that travel restrictions were not as efficacious at stemming disease spread as quarantine, testing, other methods. But again, it's more the being target about knowing where the disease is coming from, using your testing resources there. If someone tests positive, quarantining them, but restricting travel. First, you would probably, and as you know, I have been critical of the travel suspension that the administration did a few weeks ago, because I think it's got an inverted response. That it restricts legal permanent residents coming to the United States, which, as you mentioned earlier, and we discussed, they're the ones who actually have the elaborate medical screenings, but it doesn't restrict people coming on temporary non-immigrant visas, which have much less screening for medical and contagious diseases. So it's also very hard now when we don't have treatments and vaccines, because that has always been the other thing in our toolbox is to say, well, get the vaccine, and we have a lot of diseases where people are required to get a vaccine before they can come to the United States, just as we often get vaccines before we travel abroad, or require them to take medication. We don't have these for COVID. But travel restrictions that are just kind of used bluntly without having the kinds of things that I know go on in other countries where they're doing those quick fever tests of people, so that even if someone isn't, like wheezing and coughing and blue in the face, that you can use some of the more high-tech medical diagnostic tools to identify someone.
And I remember during the Ebola epidemic, one of the things we did say, and we got the cooperation of other countries and airlines, is to test people at least for temperature and symptoms before they departed, right?
Exactly.
So we weren't waiting on people to arrive. We had that cooperation going. The restrictions were targeted. If you had been in that country in the last several days, we wanted you to be tested before you could come. So, but to be fair, even Ebola, even H1N1, those seem to be, even though they were eventually epidemics and some pandemics, certainly not as virulent as what we're seeing right now in COVID-19. And the other thing that I seem to notice is that almost all of those precautions, if you will, in travel came after we had already seen cases in the US.
Yes, but it was before the diseases had spread so widely. So we had had a few cases, but within a few weeks, we started imposing those. When it became clear that these diseases were highly contagious, but even in those earlier ones, the diseases were concentrated in specific regions or countries. So it was a lot easier to have a targeted response and do the very things you mentioned of assessing people before they got on a plane, doing a health assessment, as well as, when they arrived here, of being much more strategic. The fact that COVID-19 was pervasive almost across the world, by the time we started kicking in a response, makes those options much more difficult, because you really would have to be checking virtually all flights coming in, or all people getting, and negotiating with so many more countries before to get permission to screen people before they got on a plane, because that's a sovereignty question. So a lot of countries are not going to let U.S. officials. And if we have medical professionals, we kind of want them here right now because we need them.
Yeah. Yeah.
So
yeah, that's true. Well, we've got some efforts underway to keep the medical professionals were excluded from the immigration executive
yes, they
order.
were.
The medical professionals could still come in, because so we still want doctors and nurses to come in. One last question I just want to ask is, thinking about this, if we were to think past our current COVID-19 emergency, one thing I know is after 9/11, we learned a lot of lessons about how our immigration system was used by the perpetrators of that to take advantage of that. Or we did a lot of changes to how we look at and mitigate the potential of our immigration and border control systems and transportation systems to be used for terrorism. Putting on your little thinking cap here, looking ahead, what do you think that the lessons learned from this pandemic will mean for how we address these kinds of things and try to mitigate these threats in the future? We've had several now in the recent 21st century, as you noted, everything from SARS to MERS to H1N1 and swine flu and Ebola and now COVID. What changes do you think we need to actually think about permanently making to our systems to be able to be maybe more responsive, but proactive as opposed to reactive?
Well, a couple of things come to mind, and it's some of which are technical, or involve technology, and that's making sure that people that are CBP officials and have the highest quality medical screening devices that someone who's not a medical professional could use to check for temperatures, that those are available to them. And just to do a quick check if someone looks funny, so that we're not always dependent on a medical professional. And so the extent to which technology, just like we did with terrorism, we learned that, technology can do a lot of screening, even though there's no substitute for face-to-face. We know through telehealth that, and we're learning in working with rural and remote areas of the United States, that there's a lot we could do with telehealth that could help us, so that we don't have to, again, have health professionals around at every location. So technology and telehealth can be a big help for us and should be part of the planning in the future. But we still need people, and recognizing it always has struck me that we ratcheted up border security in terms of Border Patrol and CBP officers in major ways without thinking about what complements what they do, whether it's the public health service, whether it's immigration judges or other people that work on inadmissibility and screening, having a more complete and robust system that is looking at a whole host of things, and then cooperative agreements with the other countries on these things. So good relations, because it's in everyone's best interest that these diseases are not always crossing borders, and it's for the world's safety that we try to be more intelligent and use the best that technology has to help us be ahead of the game. To try to have these, so having a good planning system, contingency plans that can be kicked in when as needed, and and making sure that we regularly revisit those plans before there's a crisis to make sure, is this still the best technology? Is this what's available? Do we have the people? Are we ready to go? Because if you wait until it happens,
it's too late.
It's too late. That's what we're living with now. And when our early settlers, when the Europeans came to this hemisphere, we brought a lot of diseases. And millions of the indigenous inhabitants died as a result of our arrival. So what we're talking about is not a 21st century problem. It's as old as time.
When people first started traveling, they brought their diseases with them, and now we have to figure out how we deal with that.
And I would like to think we're more sophisticated and have the knowledge and the technology and the insights and the planning in place to be able to contain when these highly contagious. It's really about trying to contain them while we work on vaccines and medications. And I think that a better, more systematic health screening that would be invaluable, not just for us, but worldwide.
Well, Ruth Wasem, thank you very much for joining us on this podcast. We look forward to the next time you can join us to give us a little background in history and your insights from your great experience. Thank you so much for joining us.
It's been a pleasure, Theresa. Bye-bye.
That's our show for this week. We'll be back in 2 weeks, but before we go, a quick reminder: subscribe, rate, and review this podcast on Apple Podcasts, Google Play, Stitcher, Spotify, or your favorite platform. You can also find more information on all the stories we discuss here on the show at bipartisanpolicy.org/immigration. This Week in Immigration was created by Theresa Cardinal Brown and myself. The executive producer of This Week in Immigration is Theresa Cardinal Brown. And this week's episode was written by Theresa Cardinal Brown and myself. Our producers are Chris Ramon and Yafat Tawahata, and our editor is Yafat Tawahata. The executive producer of BPC Podcasts is Ashley Swearingen. I'm Jordan Lapierre. Join us again next time on This Week in Immigration.